Hello guys, welcome to my YouTube channel. I am Denmark Aranas, a postgraduate medical intern, and I basically provide informative videos to medical students. And also, I give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe to my channel and click the notification bell to be updated for my new videos that I'll be posting every week. This video is part of my History and PE series. However, for this, I'll be more concerned with mental state examination, as this is vital for our topic relating to psychiatric interview. So for today, I will discuss psychiatric history taking and mental state examination. This is dedicated to all of the patients I interviewed in my psychiatry rotation during clerkship. I thank you all for teaching me how to be more empathic and sensitive to people who are suffering from mental illness. I would like to encourage people to seek psychiatric consult as freely and as natural as it can be, like any other diseases we seek help for. We should stop taking mental health for granted, for this is central to the well-being of every individual. Let us give our patients holistic treatment by giving importance as well to their psychiatric needs. So here's the topic outline. First, I will give you the important psychiatric interview concepts and then followed by the techniques of interview, and then the phases of interview, and then we'll go to the psychiatric history taking proper, and then lastly, the mental status examination. Okay, let's start. Here are the important concepts of doing psychiatric interview. First and foremost, establishing good rapport to the patient. A good rapport ensures safety, privacy, and confidentiality. These factors will help you gain their trust and confidence in confiding their feelings and problems to you. The room where you will interview should be well lit, quiet, and arranged for one-on-one interview. It is also good to prepare a glass of water and a box of tissue near the patient in cases of emotional sharing. On your part, please make sure you have a pen and paper for note taking, and then position in such a way that you sit near the exit in cases wherein patient might get aggressive to ensure your safety as well. Then, you have to assure your patient that everything that he or she will share will be treated with great confidentiality. However, take note of this. In cases where patient tells you that he will harm his or herself or will intend to harm others, that would be the time to break confidentiality because it is your duty and obligation to disclose such plans of suicide or homicide to protect all that is involved. Okay? Remember that. Doing all these things will increase the likelihood of good participation of the patient. During the interview, should always exhibit a non-judgmental attitude and be careful of your nonverbal cues. Always have a neutral look on your face and don't show any expression of disbelief or disapproval, for that would trigger inhibitions of your patient. Next is empathy. You should note that it takes observant eyes to see the pain, but a sincere heart to help weighing it. Put yourself in the patient's situation and acknowledge that what they are feeling is valid and that you are there to help and support. And among these concepts, I would like to put more emphasis on active listening, for this is the key skill of a good psychiatrist. So there are 5 active listening skills that an effective psychiatrist always employs. These are attending, bracketing, leading, reflecting, and probing. We'll go through this one by one. First is attending. This is the nonverbal communication that tells the patient that you are listening and paying attention. As you can see in the picture, the doctor or psychiatrist is leaning forward with the head tilted slightly and having direct eye contact with his patient. That is the best example of proper way of attending to a psychiatric patient. Next is bracketing. Bracketing is a mental skill that psychiatrists employ to set aside their emotional based biases from their own feelings and thoughts. There are two forms of biases under bracketing, one from the patient and the other from the doctor. We call the emotional bias of the patient as transference. Okay? The patient sees the doctor as someone from his or her past. Let's say, for example, this patient remembers her dad, and she assumed that the doctor would be just like her dad, who laughs at her at times of weakness. Now, the doctor's emotional bias is called countertransference, where here, for example, the doctor recalls someone in her past by interviewing the patient. The doctor, for example, could see the patient as her own son or daughter who passed away. Okay, so these biases, the transference from the patient and countertransference from the doctor, should be bracketed or set aside to provide a good environment and a good relationship between the doctor and the patient. You, as a psychiatrist, should develop this mental skill for you to avoid being drained or consumed by your feelings and thoughts. This is very difficult, and the best psychiatrists are really good at practicing this from years of experience. Third active listening skill is leading. Here we have two types, the indirect and direct. For indirect, this is just an open invitation by the psychiatrist to the patient to talk about anything he or she wishes. Here, the psychiatrist could ask, "What would you like to talk about?" and continue encouraging the patient to share by saying, "Yes, go on," and then. While direct leading is about guiding the patient sharing, and here the patient wants to know more about certain details. This is done by saying, "Tell me more about this feeling or thought." Another amazing skill of psychiatrists is reflecting. Psychiatrists act as a mirror and reflects back to the patient what he or she is thinking and feeling so that the patient sees him or herself clearly. They do this by reflecting on three things: the content or the story that the patient shared, the feeling that the patient showed, and the nonverbal behaviors that the psychiatrist observed. Reflecting on content is done by paraphrasing the story that the patient shared and confirming to the patient if you heard it and understand it right. And that is called perception checking. As for the reflection on feeling, you allow the patient to recognize the feeling that they showed. For example, you could ask these questions. You seem angry with yourself and with the unfairness that happened to you. And then you seem afraid that your love will leave you. This is important for them to have a good insight of their own feelings. Then for the non-verbal behaviors, you should never disregard their simple actions. For patients, like for example, they're fidgeting or avoiding eye contact, they may be trying to hide their distress and anxiety. You recognizing this will oblige them to be honest in their sharing. The last active listening skill is probing. Here, the psychiatrist elicits more information from the patient. Here is an example where the psychiatrist probe about a certain feeling. Here, he or she starts by asking, "How does that make you feel?" And then, "Can you tell me more about that feeling?" Asking further, "What makes you feel that way the most?" Okay, so that is probing. So let's recap. The five active listening skills are attending, bracketing, leading, reflecting, and probing. Master these skills and you will be a great psychiatrist in the future. Next, let's talk about the techniques of psychiatric interview. You must know when to use open and closed-ended questions. For this will help you really in making the most out of your time. If you have limited time to see the patient, then you must employ more of the closed-ended questioning. Always make it a habit to do note taking, okay, while doing the interview because the usual interview with a psychiatric patient lasts for almost an hour. You will get a lot of info. So it is really wise to write down the key points you will know from the patient. Then you should acknowledge any signs of distress from the patient. Your patient might already be at the point of breakdown, and we do not want that to happen. We should not be forcing anything from the patient and do not make them burst into tears unnecessarily. Also, you have to summarize key points before proceeding to the next part of the history. That way, you are giving the patient the opportunity to clarify any misunderstandings. And lastly, be very observant and sensitive with your patient, for they might be hiding his or her wounds of self harm, or he or she could be faking his or her demeanor, but she really is under distress. Observe the relationship he or she has with her companions and assess if he or she is being neglected or worse, abused in their house. So it is important to always cater for the best welfare of your psychiatric patients. Always ensure that your patients will get the best support system from family and friends. We go now to the phases of psychiatric interview: the opening, middle, and closing phases. The opening phase is where you put the patient at ease by introducing yourself and getting to know him. And if there is any company with him or her, here you also inform them about the length of interview. And it is expected for a new case that it is going to take a while. You, as an interviewer, should be relaxed and professional at all times and give the best first impression to your patients. As for the middle phase, uh, by this time you should be able to identify already the major issues in the case and formulated your impression with differential diagnosis. And you should have done here most of the mental status exam. And as for the closing phase, your main objective is to share with your patient your conclusions and treatment recommendations, and then summarize what happened in the interview. Let's now go to psychiatric history taking proper. What you see here is the general components of an adult history taking we use in internal medicine. Here now are the additional components of psychiatric interview. We ask about past personal and psychiatric history, substance use, drug use, and forensic history. This will be the main focus of our discussion for history taking in psych. You may review the other general parts in my previous videos about adult history taking. Okay, so let's start. Um, After the psychiatric history taking, here are the components of mental status exam. So if you would combine both, it is pretty lengthy. So you see, that's why psychiatric interview usually lasts for an hour or even an hour and a half. So for the past personal and psychiatric history, here we ask about the relationship that the patient has with his or her family, his schooling, if she experienced any bullying at school at a young age, his or her occupations, if uh, he or she is being exposed to stressors due to work, the condition of the marriage your patient has, if it is stable, and we also ask if he or she had any history of abuse, either sexually or physically. and if the patient has any previous suicide attempts. And also, we ask if they have been previously diagnosed with any psychiatric illness, if they are taking any current medications for psychiatric disease. Next is substance use. We ask the age of onset of this substance use. Uh, for example, alcohol, cigarette smoking, illicit drugs like uh, marijuana, cocaine, and the others. We ask about the pattern of use and the relationship to its symptoms, and the psychological dependency, wherein the patient thinks that taking the substance really helped alleviate their symptoms. And as for physical dependency, they would show withdrawal symptoms like tremors and palpitations. And when they take the substance, they would feel relieved. That is why they think that their uh, conditions being cured by taking in those substances. So that is physical dependency. It is based on the withdrawal symptoms alleviation. While psychological dependency depends on the belief that it is better for them to take it than to withhold them from taking it. Okay, next is drug history. Here we ask if they have any current medications relating to a psychiatric illness like antidepressants or antipsychotics, and if they have any drug reactions to these drugs. And also, we ask about allergies to food or drugs. And then lastly, we ask about forensic history. Here we ask about having a record of offenses, if it is repeated or persistent, and the relationship to symptoms of these offenses. We now go to mental status examination. Here again are the components of mental status exam. We'll go through each one by one. Okay. As for the general description, we take note of three things: the appearance, the overt behavior and psychomotor activity, and the attitude towards the examiner. As for the appearance, here are the things you have to take note of. I would just like to highlight clothing there, okay? Please be wary if your patient comes to you wearing long sleeves or jacket in a hot weather. They may be hiding some scars or bruises underneath. For the behavior, I would like to highlight here patients' restlessness. They may be exhibiting panic or having anxiety distress, or they may be hearing or seeing things out of ordinary, and you may need to give them sedative to calm down first. And then for attitude, I'm really asking you to extend your patience for difficult ones. They are doing things involuntarily from the imbalance of chemicals in their brains. So you must always understand their different attitudes. Some may even be seductive. Please maintain your professionalism as always and explain the boundaries of clinician-patient relationship that you must always abide. And do not lose interest to your apathetic patients. They may be really wanting your help, but they just have been so helpless, which you must help them cope with. So please never give up to any of your difficult patients. They only need one person to believe in them, so be their number one support. Remember that. Next is mood. Dysphoric state is the mental suffering from being depressed. Euthymic is the state of joy or bliss. Expansive is the unrestrained emotional expression. Elevated mood is the state of enthusiasm. Euphoria is the state of intense excitement and happiness. Anhedonia is the lack of interest in doing things. Elation is the state of great happiness. Alexithymia is the inability to express or describe one's own emotions. Okay. The other uh, words here are self-explanatory, so I wouldn't tell you its definition already. Okay. So we move on to affect. Affect simply means emotions. Okay. So if the patient's story is sad, their emotions should also be sad. If happy, then they should exhibit happiness, like smiling or laughing. These emotions we classify according to range, if full, constricted, blunted, or flat. Okay? Take note of that. And as for speech characteristics, we identify the quantity, if adequate or not, and if the rate of production is poor or not, and if the quality of speech is soft or loud spoken. Okay? Next is perception. We identify if they experience hallucinations or illusions. Hallucinations are those uh, without stimulus, okay, while illusions are those induced by a stimulus. Hallucinations occurs primarily from inappropriate perception in the brain, okay? It could be auditory, like hearing voices or whispering people, visual, like seeing out of this world images, tactile, like feeling something crawling under their skin, smelling weird odors or even foul odors, even though it is not present, or even tasting weird flavors from regular food. So, those are the types of hallucinations your psychiatric patients may experience. Okay? If they could explain what they are experiencing, it may be due to illusions, okay? Illusions only. And if not, then that would be identified as hallucinations. Next is the thought content and mental trends. Under these are the thought process and content of thought. As for the thought process, check if the patient exhibit any of this upon answering your questions. I would just like to highlight tangentiality and circumstantiality, wherein patient beat around the bush before really answering your question, and they provide unnecessary details, which would then eventually answer the question. Next, as for content of thought, delusions are the false beliefs that the patient has. Like, for example, he or she might think that he or she has superpowers or that they are famous celebrities. Phobias are the great fears that they have. Be wary about suicidal or homicidal thoughts. And in that case, remember I said a while ago, that is the time that you will break confidentiality to save someone's life. Okay? We now go to check for sensorium and cognition. And under it, we assess a lot of things. Let's start with consciousness. Here we observe if the patient is disoriented, confused, drowsy, or even the extreme of coma. And to check for orientation and memory, we ask the patient about the date, time, and their awareness of the place where they are. We ask if they know their full name and the full name of their companion. Then for memory, we ask about remote data like their birthday and recent past, like any place they visited for the past month. Recent memory would be the meal that they took for breakfast. And as for immediate recall, we make them memorize three unrelated things and then ask after 3 minutes the three words. And if they recall uh, this, and the usual things we ask them to memorize will be mingo, table, and coin. Okay. Next is concentration. Here are the tests that we usually do. The series of 7 is asking the patient to subtract a series of 7 starting from 100. Like uh, from 100, the next number should be 93, and then 86, and then down the line. So you continuously allow the patient to subtract 7 from 100. Next, next test is the allowing the patient to spell word backwards. So the correct answer to that would be DROW. Okay, or you could also ask the patient to recite the alphabet backwards and also the months backwards. Okay. And then lastly, you could ask the patient to repeat the sentence, no ifs and or buts. So these are the tests for concentration and attention. But you don't have to do it all. All you have to do is to choose from the list two, okay? Like for example, you could ask them to recite the alphabet and months backwards, and that would be enough, okay? As for reading and writing, you give these instructions on a piece of paper and hand it to the patient. And if they were able to do it all, then they are literate, okay? As for visual spatial ability, ask the patient to draw a clock and then copy a figure of interlocking pentagon as shown here. Okay. As for the abstract thought, allow them to explain these simple proverbs. Okay. Or ask about the similarities between objects, like here. Next, if we test information and intelligence, we ask them to calculate simple math problems like subtraction or multiplication. And then for vocabulary, we ask them to define simple words. And as for the general knowledge, we ask them if they know who our current president is. Next is judgment and insight. Here we give them imaginary situations, like here, for example, what would you do if someone dropped his wallet while walking? As the correct answer to that is to return immediately the wallet to the patient who dropped it. So that is good judgment. As for insight, we ask if the patient knows about his or her condition and ask if he or she thinks that she is sick and needs treatment. Having a good insight would be a great help in maintaining compliance with medications and patient education. Okay, well, that ends our mental status exam. You see, it is pretty long. We do this for new cases or new patients who come in the clinic. But for those who come only for follow-up, we only do the mini mental status exam. Here is the shortened version, and we ask about orientation, registration of the three words, unrelated words, the mango, table, and coin, and then we test for attention and calculation. Okay. And then later, we ask them to recall the three words that we ask them to memorize, the mango, table, and coin. And then we proceed to testing language, their reading and writing, and visual spatial ability. Okay. And the total score that they may get is 30 points, as you can see here. Okay. And if they score less than 27 points, then that may indicate impaired cognitive function. Okay. So this is the mini MSE. Okay. And at the closing phase, psychiatrist will be sharing his or her assessment of the patient's condition. And they use these two guidelines, the ICD-10 and the DSM-5. Okay. I tabulated here the equivalent diagnosis for the two. For example, in ICD-10, the paranoid hebephrenic, catatonic, and undifferentiated schizophrenia are all equivalent to DSM-5 as schizophrenia, multiple our first episode, currently in acute episode. Okay? So there are a lot of psychiatric illnesses that a psychiatrist may consider, as you can see here, from mental retardation to post-traumatic stress disorder. Okay? And among it all, I am not ashamed to share with you that I was diagnosed with major depressive disorder, recurrent episode, severe, with psychotic symptoms. And I would just like to end this presentation by leaving you this message. Okay? Having depression is tough, but my determination to reach for my dreams is way tougher. Okay, thank you for listening and have a good day.